It's now time for our next speaker, Professor Aziz Sheikh, who is on the line from Scotland, incidentally where I grew up. So Professor Sheikh, he is a director of the Usher Institute, which catalyzes the transformation of health in society by working with people, populations and their data. He's also director of the Asthma UK Centre for Applied Research, co-director of the NHS Digital Academy, former visiting professor of medicine at Harvard University, and an editorial board member of BMC Medicine and the Journal of the Royal Society of Medicine. Assalamu alaikum, Professor. Thank you so much for joining us, despite your busy schedule. How are all our fellow Scots doing there?
Okay, assalamu alaikum. Thanks very much indeed for the welcome, Farhan. Yes, I mean, I think everybody's doing well. Alhamdulillah, yeah.
Good, good, alhamdulillah. So, well, I'll hand over to you now, Sheikh, to do your presentation, please. Thank you.
All right, so Bismillah. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Alhamdulillahi rabbil alameen. Wassalatu wassalamu ala rasulihil kareem. So, I mean, I think the first thing I wanted to say is thank you very much indeed for the opportunity to contribute to, I think, this important summit. And it's great just to have the opportunity to connect up again with IIDR and the really very important work that that you guys are doing. So thank you for that. What I've been asked to do is speak around some of the epidemiological considerations around COVID-19. So I'm very happy to do that. And what I do hope is that there will be the opportunity for plenty of time for discussion. And towards the end, I realise that we're running a bit late, but I'll try and make up a bit of time. So what I plan to do is discuss briefly around some of the origins and spread of COVID-19. I'll talk a bit about clinical considerations, some of the consequences of the disease, and then as far as possible, and this is really very difficult, looking at what the future might hold in the short term and then in the longer term, and then offer some conclusions. And again, as I said, I mean, I hope plenty of time for discussion. I wonder if you could just share the first poll question before I get into all of this. Can you activate that?
Just 2 seconds, bringing that up.
No, it wasn't that one, it was a different one. It's around whether people think they've had COVID-19. Okay, so the first question is whether you think you've had COVID-19. So simple yes or no. I'd be grateful if you could click one of those two options, please. Okay, so can we get the results up? Okay, interesting. Great. Okay, so 18% yes and 82% no. Okay, fantastic. Thank you. Right. Okay, so let's get cracking. So where is this progressing? What I want to do is first is just give a few disclaimers. So as Farhan said, I have a number of affiliations, including working with government on some of these issues, but here I'm speaking entirely in a personal capacity. Also want to make mention of the fact that this is an incredibly rapid evolving field. So the scientific community has come together in ways that are absolutely unprecedented. A lot of national, international cooperation. This volume of literature is amassing by the minute. And so I think it's next to impossible already for anybody to have a complete command of this literature. And so there may be sort of dimensions of it that I don't know, or the literature has moved on since I last looked at it. So I think it's important for that. To paraphrase and quote Donald Rumsfeld, or at least a part of his quote, it's a very new condition, a new disease, so lots of known unknowns and even more perhaps unknown unknowns. So please bear that in mind as you hear what I mention. And I appreciate that this is not a scientific meeting per se. I have been given this topic. What I'll try and do is I'll speak in as lay terms as possible, try and avoid technical terms. If anybody wants to have a more technical scientific discussion, I'll give you my details at the end. I'm very happy to do that on a one-to-one basis. What I will do is mention some key terms that I'm going to mention in the course of this short presentation. So the first comes up in the title, epidemiology.
For a second,
yeah.
Professor, if you could just move your camera slightly to your right, if you don't mind.
Okay.
Give a better view to the viewers.
Is that any better?
That's much better. Thank you.
Okay. All right, so epidemiology comes up in the title, and epidemiologists are certainly in vogue at the moment, certainly in the UK and I think globally. So it's, and this is because epidemiologists are fundamentally interested in what disease looks like in populations. So I'm trained as an epidemiologist, so I think it's really important to see this, this aspect of scholarship coming to the fore at this time. Modelling, you'll have heard a lot of that term. Clearly it can be used in a number of ways, but in this context, I'm using the term in relation to a mathematical attempt to best guess reality and project what that will be going forward. One of the kind of caveats here is that all modelling is wrong inherently, because projecting into the future is incredibly difficult. It's just that some models are more wrong than others, and we'll talk a bit about modelling in due course. So Hassan has already mentioned in the previous presentation around pandemics. He was using this term almost synonymously with plagues. I'll use the word pandemic, and what this refers to is the spread of a condition, and we're talking particularly in this context around communicable or infectious disorders as they spread across countries, and in the World Health Organization definition across whole regional areas or continents. And a virus, you'll have to go back to your kind of days of biology, but a virus is a microscopic organism that can really, it's different from other microscopic organisms that it only multiplies within the host. And that's here, again, another important consideration. So in terms of the origins and spread of COVID-19, hopefully, most of you will now be aware there's been no shortage of media covering around this, but it's caused by a virus, a new virus called SARS-CoV-2. Previously it was called nCoV, but now this is the correct nomenclature for it, as advocated by WHO. This has gone to a technical committee. This will hopefully be ratified in due course, but this is the term that we're talking about. So people who've got the virus, it's SARS-CoV-2, those who become symptomatic, we're talking about the disease COVID-19. A very, very new disease. So the first official description of this was from Wuhan, the capital of Hubei in China, and this was at the end of December 2019. So, and what was happening there was there were a number of cases of pneumonia, so infections of the chest, but these were unusual, and this virus was identified from these patients. It was reported to the WHO, or the World Health Organization, at the end of last year, and we're still unclear, but it seems that its origins were not, it seems likely that originated from bats, but bats through another vector, so another host organism, and the pangolin is the one that's thought to be most implicated here. So within Wuhan, it's the wet markets that have been implicated, and bats and pangolin are consumed within and sold within these wet markets. So this is the current thinking. I mean, it will be clarified in due course, I'm sure, inshallah. And this is a microscopic image of this virus. So I mean, it's actually a very beautiful virus. And I mean, when you look at it under that electronic microscopic image, but obviously causing I mean, a great deal of difficulty and distress and death across the globe in very, very rapid time. So after that initial move into humans, the main vehicle has subsequently been human-to-human spread. And it spread mainly through droplets. So as a result of coughing, sneezing, and speaking. And droplets are pretty heavy particles. And so direct transmission typically occurs within a distance of around 1 meter. And hence we've got these kind of safe distancing rules that are being advocated not only in the UK, but globally around 2 meters, just to be ensure that we're safe. So these droplets settle very rapidly and they settle onto surfaces. And what then happens is that the main way that this is being transmitted is that people are touching these infected surfaces. And then the main way in which we become infected is by the virus entering through one of the mucosal surfaces. And by mucosal surfaces, I mean the eyes or the conjunctiva, the nose and the mouth. Rigorous hand washing with soap or with, using alcohol does destroy the virus, and this is why there's been so much emphasis on hand hygiene. What we're learning is that this virus can last on certain surfaces, such as plastic, for up to 72 hours. So this has then been incredibly challenging in terms of trying to maintain sterile environments. The WHO has made mention of this, and this is, for example, one of the main posters that they put out, or infographics, and it's really to try and emphasize the fact that this is droplet spread predominantly rather than airborne spread. And so as a result of social distancing rules and hand hygiene, we should be able to prevent the majority of this spread. The timeline, just very briefly, it's been a very, very aggressive timeline. So it seems like the first cases actually were picked up in China in the early parts of December. It seems like some of that information was suppressed, not notified to the WHO, as it should have been very early on. So a bit of a delay there. We had the first cases outside mainland China by mid-January, and then outside to North America by the 21st of January, and that was a traveler returning from Wuhan. And then on the 23rd of January, the whole of Wuhan, 11 million people, so around the size of Greater London, were put into quarantine. And as you'll have seen from the news, that quarantine is in the process of being lifted in part, at the moment. We had our first cases in the UK on the 29th of January. At the end of January, the WHO raised its kind of emergency level, declaring this as a public health emergency of international concern. And then they went to their highest level on the 11th of March, declaring it as a pandemic. So these are updated figures that I took off last night. I think it's the same source that Hassan was using. This is the Johns Hopkins tracker. And I think it's a phenomenal contribution that they're making here. So as you can see, now 185 countries have reported cases out of sort of 195 jurisdictions in the world. 1.6 million confirmed cases, and we've surpassed, unfortunately, over 100,000 deaths. So very, very aggressive timeline, as you can see. And what we have there on the left are the leading number of confirmed cases. And as you can see, for those of you in the UK, and I see the audience is predominantly UK, unfortunately, we're very high on that league table. But wherever you are in the world, you can go to this site. So it's a Johns Hopkins site, and you can see how your country is performing. I want to emphasize that these are probably underestimates, because diagnostic capabilities are still in very many parts of the world limited, both in terms of confirmed cases and in terms of deaths, unfortunately. What you can also do, and this is from the CDC, so the Communicable Disease Surveillance Centre for Europe, is look at what the trajectory is like in individual countries. And so what I've done is highlighted the trajectory for the UK over the, I pulled this off late last night. And as you can see, this curve is increasing, but there seems to be a bit of levelling off as a result of these social quarantine measures. Other countries are doing significantly better. And what you can see is that, at the moment we're in a situation where we're probably doubling in terms of number of cases between every 3 and 4 days in the UK. We want to begin to bend that curve and begin to bend that very quickly. In terms of more clinical considerations, and so this is, I'm talking about sort of how this disease presents. So what we now know is that there are lots of people who've contracted this virus but have no symptoms. So they are asymptomatic. What's important here is that these individuals can transmit the disease. So they are harbors, they are vectors. They can pass it on to others. Most of those who actually contract the disease and develop symptoms are not too badly affected, thankfully. A minority, around 10%, tend to require hospitalization. The vast majority can be managed quite safely in the community. Now, a subset of those, and it's not sort of entirely clear, but probably around 30% of those will require some form of admission to intensive care, and a smaller subset still will require ventilation. So, for example, the UK Prime Minister, Boris Johnson, fell into that category of needing intensive care unit admission. Thankfully, he didn't require ventilation, and thankfully he's now out of that situation. What we do know is that the poorest outcomes tend to be in males, the elderly, and those with underlying conditions, and particularly underlying heart disease, diabetes, blood pressure problems. Overall, the death rate, or case fatality rate, as we call it in epidemiological parlance, is less than 1%. So less than 1% of individuals who are contracting this disease are dying. But because so many people are contracting it, this is why the numbers of deaths are so high. Let's move on. So the main symptoms are fever, new onset of dry cough, tiredness, muscle pain, loss of smell and taste. Now, the fever and new onset of dry cough are the ones that are being used for a clinical diagnosis of COVID-19 at the moment. So those where there is no testing capability or testing is currently not advised. So if individuals have a new onset of fever that's persistent and a new onset of cough that is again persistent, we are in effect treating that as a diagnosis of COVID-19. Some of these other symptoms are actually more common, such as tiredness, and loss of smell and taste seem to be pretty specific to COVID-19. So that seems to have an important bearing. What concerns us as clinicians are the breathing difficulties that people run into, because this is this is what typically requires intensive care unit admission and support with breathing or ventilation. So as I've already mentioned, social distancing is a really important consideration here. And this is because individuals may be infected for up to 14 days before they develop symptoms, and for up to 7 days after developing symptoms. So we're talking about a 21-day period here, potentially, for individuals. And going forward, what's going to happen in individual countries and globally is very, very dependent on how effective we are with social distancing. Because this is a virus that spreads incredibly rapidly, as we all now know. So we talk in technical terms about the R0, or how many individuals can become infected from an individual case. So this social distancing and protection is particularly important for those who've got symptoms, those who've been exposed to somebody with symptoms, whether suspected or confirmed disease, and those who are most vulnerable in our community, and those are at highest risk of poor outcomes, who need shielding. So the shielded groups are well identified. I'm not going to go into detail around this, but really public health agencies across the world are identifying these groups. So these are data from Public Health England, for example, and replicated in Scotland. So the groups who are most likely to suffer poor outcomes. And for these individuals, what we need to do is really try and minimize any contact with the external world for these individuals. So we're asking them not to leave their homes at all, and we're asking them to avoid non-essential contact, even with members of their households, until we've got some of these curves bended, flattened, as the terminology people are generally using. So in terms of the consequences, what we know is, substantial amount of morbidity, ill health, using sort of lay terms, and lots of deaths directly resulting from COVID-19. We already know that there's actually a lot of psychological harm. So anxiety, depression is beginning to set in. There's a lot of loneliness in our communities, unfortunately, particularly in where people are being shielded or in single people households. What we're also seeing is that there's a lot of disruption to normal services. So for example, in the UK, community services or primary care or GP services are really struggling. They're having to try and manage the risk to staff, to fellow patients, while also providing routine models of care. So routine care is unfortunately really disrupted at the moment. So we're seeing a sharp decline in usage of accident and emergency departments, a reduction in non-emergency surgery, hospitalizations for other contexts. Outpatient appointments are reduced in many in contexts. So routine care at the moment has not got back to normal because we're still in the process of trying to work this all out. What's already beginning to happen as a result of that, there's excess mortality or deaths from other conditions. We're already beginning to see some of that. I think down the line, this is going to become even more challenging because, as we know, a lot of people are being thrown into real economic challenges. And I think this will be felt predominantly within some of our minority faith and ethnic communities in the UK and elsewhere, because when we know we have, for example, in the British Muslim community, a lot of people who run small businesses, many of those are closed. We have the restaurants and takeaways. We have a lot of people working as cab or Uber drivers, for example. A lot of these businesses are really not able to function at the moment because of the lockdown measures in the UK and elsewhere. What we know is from previous pandemics, and some data already beginning to emerge, are increases in domestic violence as a result of people really being forced to be together. Hassan had a very different perspective on this. I think that's an important perspective, but there is a kind of a flip side to this as well. So domestic violence, is unfortunately increasing. What we know, again, from previous pandemics, is that we can expect increases in divorce as a result of this forcing of people together in confined spaces over prolonged periods of time. And the diseases of despair, as they've been so called, we can anticipate that these will increase. And these are diseases linked with issues to do with alcohol, drugs, and suicides. And previous pandemics, have been associated with, or epidemics have been associated with substantial increases in suicide. So I think there's a kind of an immediate challenge for health systems, but I think what we're trying to brace ourselves for and trying to work out is how do we respond to probably an even bigger challenge, which is imminent. It's already starting. I think we also all know that what we need to try and look for are any silver lining. And so, I put benefits in inverted commas. So we are beginning to see data suggesting reductions in road traffic accidents. These are very important sort of causes of morbidity and mortality, particularly in the Muslim world, where unfortunately we still haven't got quite our act together in this respect. So certainly substantial reductions anticipated in that context. Hassan was talking about improvements in air quality, and so as I hope you're getting out for your daily walks and a bit of exercise while we're allowed to do that, and the bird song, certainly it's very, very evident, and it's incredibly refreshing to be able to hear that. So improvements in air quality, and air quality is probably one of the biggest public health emergencies that there is on the globe. So in that respect, really an important unanticipated sort of consequence or a benefit that we're beginning to see. And I think what I also wanted to do was just pick up on what Hassan was saying. I mean, we're seeing phenomenal civic engagements, volunteering efforts, localism on an unprecedented scale. And I think it's really great to see that, I mean, all of our communities are doing this. And we're working across faith communities or sort of, I mean, just civic agencies in general, coming together, pulling together to try and support each other at this incredibly difficult time. And long may that continue. I mean, I think as we come through this, we must not lose sight of that, because I think that is really one of the kind of greatest blessings to emerge out of this really very difficult hour that we find ourselves in. So I want to just, in the last few minutes, just move on and talk about, I mean, what the future may look like. And I mean, of course, there are a lot of caveats around this, because this is incredibly difficult. And I mean, always, I mean, when we're talking about sort of things that we don't know about, kind of, I mean, prefix this with Allah alim. I mean, Allah knows best. I mean, we can only have a guess. But this modeling is an important consideration. So many of you will have seen the data from Neil Ferguson and Aswaghani and colleagues from Imperial College and the London School of Hygiene for the UK and the US, and that has kind of really shaped UK and, I mean, increasingly US discourse. Many countries do not have that capacity for modelling. So there's another group, a really important group, the Institute of Health Metrics and Evaluation, and they have begun to get involved in this and produced projections really now for most countries, and these have only come out very recently. So what the future holds, and I'll share those data with you in a second. So unclear in the short term. And as I said previously, this social distancing is absolutely crucial because it really depends very much on what we can achieve there, because what it will do is it will change, I mean, how I mean, this disease spreads in our communities. So I mean, I think it's really important that we understand that and get that message out. There are drug trials underway in China, in the UK, in the US, elsewhere, and some of those will begin to report by the summer. And what we hope is that, inshallah, God willing, I mean, some of these will offer a lifeline. They will help us deal with those most severely affected with those. What it seems like is that we will have some form of social distancing for the foreseeable future. There is no vaccine imminent. I mean, vaccine probably, I mean, not at least for around 12, 18 months, and that is if everything goes as smoothly as possible. So social distancing is, I mean, here for the foreseeable future, as far as we can tell. What that then will mean is that there will be substantial reductions in international travel, because any international travel will be associated with quarantine. So quarantine for those periods of time that I was talking about. So anybody who moves or when they come back to their base will need to be isolated for lengthy periods of time. I mean, to try and prevent, I mean, re-emergence of disease in those countries. And I said, vaccines, I mean, certainly there's a lot of activity here, but I mean, we shouldn't be thinking about this as anything in the short term, over the next 12 months at least. So this is why, and these are data from the UK that I pulled off, and so what we're seeing here is that we're anticipating our peak, depending on different models, over the course of the next week or the sort of next month in the UK. What we have is in the solid line there is the capacity in the NHS to be able to respond. So that's NHS beds, hospital beds, and the green line is ventilatory and ICU capacity, or many ICU capacity. And so what we're trying to do is try to create, I mean, or flatten that peak. So what we have is, I mean, that mismatch that there is between demand and, I mean, what this kind of epidemic in the UK or pandemic looks like will be minimized. And so as a result of that, we can minimize the number of deaths that there will be. And so as you can see, I mean, the more we can flatten this curve, I mean, the better the situation for us. And it's an incredible mismatch projected at the moment. So this is one scenario. I mean, there are other scenarios which actually look, I mean, a bit more favourable. And as you can see, I mean, in the UK and elsewhere, there is enormous work going on to try and develop capacity, both in terms of hospital beds with new hospitals opening up, the Nightingale hospitals, and developing capacity in terms of ventilatory capacity. In terms of what we're looking at in terms of deaths, I mean, there are, I mean, again, these projections are very, very varied, but this is the latest set of projections that have come out. from the Institute of Health Metrics and Evaluation in Washington, Seattle. So this is a group that does the global burden of disease work. So this is, a scenario that is being modeled. So overall around 66,000 deaths by August. There are other pronouncements that mean that there will be less. Inshallah, the other ones will be sort of more on the money. But let's see. But so much of this is potentially, God willing, modifiable. So in terms of conclusions, this is a new virus in humans. So we've only known this virus in humans for the last less than 4 months. It's highly contagious. It's spread predominantly through droplets. And as a result, it's spread by those with and without symptoms. So as a result of social distancing measures, we can sort of minimize that spread quite dramatically. The majority of those who get the disease get it relatively mildly, which is great. In a small subset will develop severe respiratory problems, and this is what tends to lead to death through, I won't go into the details of that, but that's respiratory distress. No vaccine at the moment, none for the foreseeable future, and at the moment we do not have any specific drug treatment. A number of trials underway, and let's hope that some of these turn positive and that there will be something over the course of the summer being made available. What we seem to think is that this will become part and parcel of our life. So we will need to learn to live with this until we have mass vaccination in place. And what we're now trying to do is find ways of trying to minimize the impact of lockdown and see whether we can kind of selectively lift lockdown scenarios because we are getting very, very worried around the wider economic, social, and of necessity then also the wider health implications of all of this. So that really is where the focus of attention of key decision makers is. In terms of practical suggestions, so I've been mentioning social distancing. Hassan has mentioned this, hand hygiene. Please just do take these messages to heart, disseminate those. We need to do a lot to support those who are isolated in our communities, and whatever backgrounds they come from, whatever sort of ethnic, faith, none, we are in this as communities, and our shielded members in particular. What I would suggest is if you can help support, get better data. So take a minute, download this C19 symptom tracker app. It's available both on Apple and sort of Android platforms. Fill it in on a daily basis, help us get the data that we need to inform some of this modeling. If you're in the UK and you're concerned around symptoms, call them the helpline. Do not, in the first instance, go to your GPs. We're trying to set up new models of care, so please support us in that, because we're really concerned about protecting you as individuals and also protecting other patients. It's important that general health is maintained as far as possible, and so do take the opportunity to kind of partake in the physical exercise as best as possible. And as Hassan said, this is a kind of a new way of living for all of us. It's here for the foreseeable future, so let's learn to try and make the most of this. And I won't go over, Hassan did it far better than I can, but in terms of trying to make the most of this family time and trying to work out what matters and connect both sort of, as families, but also with the more serious connections that actually matter with on high. And I think the last thing I'd say is that unfortunately I'm seeing in the Muslim community there's a lot of nonsense circulating on some of these WhatsApp channels. Some of this information, if we're propagating, we're helping to kill people. And so please, do whatever we can just to help suppress that nonsense that is circulating. It's not helpful. We should be very careful before we circulate any of that fake news. And to get that message out there, it's really, really important. This message from the NHS, it's a very, very clear message. I hope it's understood. Help disseminate that, because my concern is that there's still in some of our minority ethnic communities, some of our Muslim communities, this message is still not getting out in the way it should be. And just lastly, I think what we should do is always have hope. And so these are my contact details, so please feel free to contact me if I can be of any help if you want to follow up on any of this. But Hassan mentioned that in terms of this personal protective equipment, there's been this flight loads sent from the Turkish government to the UK. I mean, I think in the UK we're incredibly grateful for this. And on that parcel and packaging is the words of the phenomenal Maulana Rumi. And if we try and connect, I mean, this is certainly one person that we should, I think, try and connect with. So after hopelessness, there is so much hope. And after darkness, there is the much brighter sun. So I'll stop there and yeah, very happy to try and take any questions or comments. So thanks very much.
Thank you very much, Professor, for that insightful presentation. We've had so many questions coming through. I'm going to just dive right in. So the first one is from Zaino, who's asking, is it too early to predict if SARS-CoV-2 can reinfect humans seasonally just as influenza does?
So at the moment, I mean, obviously this is a question that we are very, very interested in. So our hope is that once we get the disease, individuals get the disease, that they are in effect protected. And so there have been discussions around, for example, immunity passports. I mean, I think that the US government, for example, has been talking about this. That I think is premature. There are some data emerging from South Korea that there seems to be either reactivation of disease in some individuals who've had the disease, or they're getting a second wave of infection. So at the moment, this is a very sort of live scientific question. We don't quite know the answer to this. I mean, our hope was that individuals would be protected for prolonged periods of time, and that they could be then, I mean, allowed back into, for example, normal social functioning. Certainly the data emerging from South Korea are not looking too promising, though.
Thank you very much. The next one is from Amina, who's asking, considering how COVID-19 has spread and how destructive it's been, do you have a view on whether decreasing consumption of animals could help to decrease likelihood in the future?
Well, I mean, I think the animals that seem to be implicated here, I mean, are specific ones that I mentioned. I mean, some of these have been implicated in previous epidemics as well. And so, I mean, I think the Chinese government is now trying to clamp down and regulate these wet markets. In terms of animals more generally, I mean, I'll just talk from a scientific perspective. I think this has no bearing, as far as I can tell, on sort of, I mean, other animals that are domestically consumed, I mean, all over the world. And we're talking about here sort of poultry and lamb and beef, for example. So, I mean, I think this is very specific animals implicated here.
Okay, thank you. And we've got Sarah here who's asking, what correlation does there seem to be between being overweight or obese and getting COVID-19, especially as we see that obviously weight is a contributing factor in things like diabetes, heart disease, high blood pressure. So does there seem to be any correlation with this?
So, I mean, I don't think there's any particular association with the risk of developing COVID-19 per se, as far as, I mean, the data that I've seen. But there does seem to be an increased risk of developing poor outcomes if individuals have comorbidity with other diseases. So increased weight is associated with increased risk of diabetes, heart disease, blood pressure. And so that's also very relevant. And there also seems to be an independent, weight seems to be an independent risk factor for poor outcomes as well. And I think there's a lot of discussion about whether, I mean, some of our minority ethnic and also discussions around whether the Muslim community is, I mean, particularly at risk. And one of our challenges here is trying to understand, because we know that, I mean, some of these comorbidities, diabetes, heart disease, are so much more prevalent in our communities. So, I mean, I think it's not so much around getting rid of the disease, but it's around the poor outcomes in those who develop the disease. Kind of, I mean, the wider implications here are that what we should be doing is when we're in effect stuck at home for 23 hours a day, as we are in the UK, we're only allowed out a very limited periods of time for this exercise. We certainly should be doing that to try and make sure that we, as a community, are not putting on even more weight.
Absolutely. Now we've got a few questions coming through asking about the examples of some of the fake news stories that you may have come across yourself on things like WhatsApp, Facebook, and other media platforms, and whether there is any risk. I mean, some people in particular have been talking about 5G, and I think, is there any in particular that you yourself have heard and that you can kind of reassure our viewers that those are untrue or just rumors?
Yeah, I want to take this in a kind of a wider sense here, because I mean, what we see is that this stuff circulates. It's pretty prevalent in on some of these WhatsApp groups, for example, and Facebook groups, and so so there's kind of a backdrop to all of this around how ginger and lemon and seems to come up in all sorts of contexts as a cure for cancer. I mean, it's been implicated as a cure for this as well. And I mean, if you do this, then you do not need to follow social distancing rules. I mean, a lot of this is just completely unfounded. I mean, 5G has been implicated. There's a lot of blaming that happens. I mean, so blaming initially, for example, of Chinese communities. I mean, I think that kind of stereotyping. So, I mean, so much of this is unhelpful. I mean, and when we're propagating this, and if people take this seriously, I mean, it's potentially disastrous. I mean, in this context, I mean, if as a result people lower their guard around social distancing, or I mean, as a result of, I mean, they stop taking their cancer treatment because they think now ginger is the answer, this is just nonsense. We shouldn't be implicated in any of this. And if we can help stamp it out, please do.
Good, thank you. We've got another question here that's saying, from Farhana, saying, we started off with herd immunity. Are we now paying the price for this? Or can we hope that the delay in social distancing has conferred some benefit in the long term when lockdowns are slowly lifted?
So I think in the long term, it's unclear, because what social distancing is trying to do is, it's trying to flatten the curve that I was talking about, and then reduce this mismatch between demand and supply. So that's one. And number two is it's trying to buy us time until we've got treatments available and then vaccines. I mean, until we have any of that, then what it's doing is it's really just buying time. It's not changing, I mean, the proportion of the population that are probably ultimately going to be infected. So I can understand, I mean, where that argument around herd immunity was coming from. I think the UK government is now really realizing that, I mean, and this is in part, I mean, these are very, very difficult calls. And as we get more and more data, the models improve. I mean, there is now, a different track that is being followed. Have some lives been lost, I mean, as a result of that in the short term? Then, I mean, I think so. And we can see, for example, I mean, the projections, or I mean, the trends, not necessarily the projections, but the trends we've also already seen in the UK are different from other countries that have taken a more aggressive stance to trying to formally diagnose with testing, to contact trace, and then really impose strict isolation on those individuals with confirmed disease. And Singapore, South Korea, I mean, Germany, for example, are now being looked at as examples in that respect. That said, I mean, a lot of these countries, as they're beginning to relax, they are beginning to see, I mean, second waves emerging. So these are very, very difficult calls, and we're trying to work out, I mean, answers as we speak.
Yeah, very interesting. I think one of our other viewers, Sheila, is asking about the kind of psychological impacts of lockdown, and whether the kind of propensity for it to trigger stress, would that maybe perhaps lower immunity in people, and also the worry about maybe then later on would the health system get jammed if too many people are staying at home. Have you got any thoughts on that at all?
Yeah, so I mean, I think there are certainly relationships between stress, and particularly if that's a chronic stress, and immune functioning. So I think that's a kind of a very reasonable hypothesis that this may increase the risk of infection in general, and the ability to cope with infection. So I mean, I think that's a very kind of reasonable hypothesis. I think as faith communities, we should have natural, we're not immune to any of this, but we should have vehicles that help us sort of mitigate at least some of those issues. And we should be sharing that, I mean, I think more generally. In terms of, I mean, if you have other disease and you need to seek help, I mean, my strong encouragement would be to not put off seeking help. What a lot of GP practices and hospitals now have done is develop remote models of care. So they can now provide care using the telephone or kind of some of the media that we're using here in this digital summit. So do ensure that you do seek help, because what we don't want people to do is be running into problems with these pre-existing conditions. What we want these conditions is to be proactively managed. This is a time that we really take, I mean, our own health really seriously, because that's important to us in our own rights, it's important to our families, and it's probably important to our communities and nations in ways that have never mattered before. And so it's really important that we do whatever we can to try and sort of maintain that well-being.
Okay, fantastic. We have just a couple more questions that I really want to get on because I think it would benefit people. One is an informative one, actually, which I didn't know myself, is about Sweden and how they have a lack of a lockdown. Are there any thoughts on that? Is there any kind of, what's the thinking behind that, as far as you're aware?
So there are, I mean, a number of different strategies being pursued in different parts of the world, which I think is, I mean, understandable when, I mean, there is no kind of, there's no kind of recipe here for us to follow. This is, I mean, almost unprecedented. So Sweden have, in a form, I mean, what they call, I mean, I think intelligent social distancing measures. I mean, I think one of the differences with Sweden is that they have many households which are single people households. It's a very kind of skilled workforce. And that's, I mean, across the piece in the Scandinavian countries. So in a lot of these individuals can work from home. Now, I mean, what they're kind of, I think, as we speak, go away and have a look at the curves. I mean, I think we can learn from all of these countries and see how things are, faring in real time. But I think they've got some kind of, rather peculiar circumstances that are not easily replicable in the UK or indeed many parts of the world that enables them to pursue that strategy.
Okay, and the final question I have here, which I think is quite interesting with, especially with Donald Trump's comments, are what can you tell us about hydroxychloroquine and other such treatments in treating COVID-19? Any idea, any thoughts on that?
Yeah, so this is a whole question around what we call repurposing of drugs. So these are drugs that we know are effective. And we're talking about drugs that are normally effective in the context of infective disorders, and seeing whether they may be effective in this context. So we're taking a drug and repurposing it for this new condition. So that's a reasonable hypothesis. As with all of these hypotheses, we need to, because none of these drugs are without their risks of side effects, we need to ensure that there is a kind of a sound evidence base. So my position would be for us to support the clinical trials that are now underway associated with hydroxychloroquine and other repurposed drugs. We'll get an answer very soon, inshallah, and then depending on the answer, then we know whether to use this or not. But at the moment, I don't think we have an answer at the moment.
Thank you very much. Again, thank you so much for your time, Professor, and insight. And inshallah, we hope you stay safe and take care of yourself. Assalamu alaikum.
Alaikum assalam, Farhan, and thanks very much, and thanks very much for putting this on. Really appreciate that.